This is Dr. Bhaumik, and those who are following my lecture series already familiar with my degrees. I just want to repeat, it has been a long time since I've repeated my professional qualification. So I was professor of pediatrics and chief of the division of pediatric endocrinology, Children and Women Hospital, University of South Alabama College of Medicine. I'm also a retired colonel from United States Air Force. Co-author of this study, which was published in Global Pediatrics, was Dr. Anne-Marie Coffers. She is now in University of South Alabama as a full professor of pediatrics and chief of the division of pediatric endocrinology. Today I'm going to present a case which is very rare in teenager or pediatric age group. This condition is not commonly seen by the pediatrician or even pediatric endocrinologist. And so I'm going to present a 17 years old Vietnamese American girl who was a patient of ours because she had type 1 diabetes for about 10 years. She was referred to us by primary care provider because of significant and intractable vomiting, loss of weight, and intermittent vaginal bleeding. The primary care physician felt the thyroid gland is enlarged, and he did some study which suggested hyperthyroidism, and that prompted the visit to our clinic. And I have already told you about this. Therefore, I will move it to the next slide. And the key purpose and overview is anytime there is hyperthyroidism or hypothyroidism in a patient with type 1 diabetes is considered as autoimmune thyroid disease, although most of the time it is hypothyroidism. Hashimoto's thyroiditis, however, hyperthyroidism or Graves' disease can also occur with type 1 diabetes. So that was the primary concern of primary care provider. And this case, it turned out to be a little bit different. So that's what we are going to discuss. This type 1 diabetes with non-autoimmune thyroiditis. The reason I say non-autoimmune thyroiditis because thyroid antibody test was done by primary care provider was negative. So I will discuss the mechanism and pathogenesis in workup and the mystery diagnosis of this patient with hyperthyroidism. So again, let's go pretty quickly about this girl's diabetes. She has been diabetic for 10 years, about 10 years, and regularly followed in our diabetic clinic. As she always kept her appointment, more or less has been really a good diabetic patient and also in pretty fairly good control as manifested by her hemoglobin A1C last time was 7.8, and in hemoglobin A1C was also done in pediatrician's office, primary care physician's office, that was also less than 8%. Once a year, as usual in our clinic, for any patient who has diabetes for a longer period of time, we check their thyroid function, lipid profile, kidney function, liver function. This was done about a year ago, which all were normal, within normal range. And in addition to the intractable nausea and vomiting, pediatrician's office, she also complained of intermittent heavy vaginal bleeding. She started her period at the age of 14. However, for 2 months she is not having any regular period, and that has been replaced by intermittent vaginal bleeding. She is also complaining of lower abdominal pain, episodic hypoglycemia, and as I said, the diabetic control always has been reasonable. And her vital signs in our clinic, she had upper normal systolic blood pressure, and she has tachycardia, and thyroid gland is uniformly enlarged, no nodule was palpated, and ultrasonographically thyroid measurement was consistent of 40 grams size. DTR was 2 plus, bilateral, symmetrical but somewhat brisk. And a bruit was also appreciated on listening to her thyroid mass. Physical examination also revealed she has midline lower abdominal mass originating from the pelvic area and rather consistent with about 12-week size of pregnant uterus. It's midline mass, 12-week size of pregnant uterus. We did do some other physical laboratory examination, including repetition of thyroid function test. And as you can see, her random blood sugar was reasonable, and hemoglobin A1C again 7.8. Her free T4 was very high, 5 nanogram per dl. The normal is depicted in the parenthesis. TSH was suppressed, and thyroid antibodies were negative, is not presented in this slide. Her total T3 was also significantly elevated, 468, and all other antibodies are negative, TPO, ATG, thyroid stimulating, immunoglobulin as well. Urine pregnancy test was positive, and serum ACTH, serum HCG, human chorionic gonadotropin, was extremely high, more than 150,000 MIU per ml, which is very high, and even a pregnancy with twin will have nowhere near this high level. And so that was very surprising and interesting. Quickly we did a sonogram. And this magnified transfer sonogram shows a complete hydatiform mole with small embryonic gestational sac with many an echoic cyst. And this is suggestive of a complete molar pregnancy or hydatiform mole. And patient was taken, referred to OB/GYN doctor, and this was complete DNC was done, which is the treatment. And after DNC, dilatation and curic, I just put here the table showing that diagnosis at the time, and free T4 after 3 days was already came down, and after 1 week was completely down, and 1.78 in after 3 weeks. So the T3 came down, and as you can see, the HCG after 3 weeks was 193. So I just want to discuss a little bit about hydatiform mole, as this will be an interesting discussion which will help even the OB/GYN resident or pediatric resident endocrinology fellow, because this is not something is commonly seen in a pediatric age group with or without diabetes. So there are two types of mole. One is complete and the other is partial. As I have depicted in the slide, it details because of the fact that it will be interesting for anybody who is studying for the board or want to know a little bit more. Just by reviewing my slides, they will get all the information that they like to get. Even though like this has too much information in a slide, in ideal case, the slide should be 1 or 2 liners, but my goal here is to put as much as possible in the slide, so you really don't have to run to the textbook to get the valuable and important information. So complete molar pregnancy or hydatiform mole occurs when an empty ovum is fertilized with a sperm, or sometimes could be 2 sperm cells. And it could be diploid, that paternal DNA only, no existing fetus, and partial hydatiform mole, a normal is fertilized by 2 sperm cells, and some fetal tissue or development may be noticed. Now, this is important. There is 15% risk of this condition. In an average, 15% is for persistent gestational choriocarcinoma or trophoblastic neoplasia. So this is not only that DNC is done and but there is always a 15% risk of progressing. However, it is a little bit more in adult than in children, but the percentage in children is not very well delineated or described. So partial mole, when the 2 sperm fertilized by a normal ovum. Triploid means the maternal and paternal DNA, nearly almost always coexistent features, and usually in this case, in partial mole, about 3% risk of developing trophoblastic neoplasia. So as a whole, if you take the global picture of molar pregnancy and there is some racial, and the discussion of, the study also shows that Asian and Native American women has got somewhat higher incidence of IgT4 mole. And females under the age of 20 or over 35 usually subjected to this diagnosis and the occurrence. The incident roughly around 1 in 1,000 to 2,000 pregnancies, but there is no clear-cut solid data but this is about a good figure to remember and to get the frequency. History of previous IgT4 mole of spontaneous abortion is also a known factor which might give another IgT4 mole in next pregnancy. The repetition, although high but not exactly known. So, how one would suspect the molar pregnancy or IgT4 mole? So there are three factors and three findings that taken into consideration. One is uterine enlargement inconsistent with the date of pregnancy. So if patient has got amenorrhea for about 1 month and 2 months and uterus looks really big midline, that should alarm this suspicion. And the other is consistently present in severe intractable vomiting, which is known as hyperemesis gravidarum. And this is a consistent and very troublesome. Markedly elevated human chorionic gonadotropin is the key finding also, and it is so high that even a mother with twin or even triplet would not even come close to it. Other clinical manifestation obviously is vaginal bleeding, abdominal pain, and hyperthyroidism, which was one of the presenting finding of our patient. Patient also might have preeclampsia-like syndrome, respiratory distress syndrome. And treatment is complete evacuation of uterine content by DNC. The histological confirmation of the diagnosis is very important. And hysterectomy can be justified if the mother does not desire or the family does not desire any further pregnancy. That does help to reduce the risk of trophoblastic cancer. Now let's see that review the TFT, thyroid function test, in normal pregnancy. What happened? We all know that I'm going to show you a graph, but before that, significantly low serum TSH in the first trimester, which may go down to 0.03 to 0.08, which is low, normal to really low. But the neither present a mirror image with a peak of HCG value. When the HCG value goes up and it gives small, number goes down. Low TSH is 5 trimester, therefore, is a physiological phenomenon, and as a result of that, free T4 is upper normal, occasionally could be slightly in hyperthyroid range. And this is a well known to OB/GYN physician and and most of the physician. Here I am going to show you the solid line is the TSH level in normal pregnancy, and this is, I think, is a very good diagram, and it was put by Goiner and the other, and the reference is in our text, as we will put it in the description section of our YouTube. And the round and dotted line is the human chorionic gonadotropin, or HCG. As you can see, as the TSH go down, HCG level goes up, and so this is a very good diagnosis, a diagram for people to follow. And this slide, the relation between nausea, vomiting, and HCG level, this is nicely depicted by Dr. Nibel and his colleague. And again, all the references will be in our publication. And it shows that higher this HCG level, more is the nausea and vomiting in normal pregnancy. And as HCG level comes down, and so is the frequency of nausea and vomiting. So let's study a little bit about the molar pregnancy and thyroid dysfunction. Approximately 50% of the patient with high DT4 has HCG level above 100,000. One of the UK study has shown of 196 patients, and they found to have biochemical hyperthyroidism. This is interesting. So this study shows there was 196 patients with high DT4 mole and 7% have biochemical hyperthyroidism. And there is a kind of formula, nice to remember, that for every 10,000 MIU per ml of increase in HCG, free T4 level goes up by 0.1 and TSH level goes reverse. TSH level go down by 0.1 MIU per ml. Free T4 level goes up by 0.1. And obviously the reason that we'll be discussing a little bit more, and there is an analogy of the structure between HCG and TSH. We know that TSH is a glycoprotein hormone, and there are other glycoprotein hormones, FSH, LH, and HCG. They have similar alpha subunit, and beta units only differ by one amino acid. So there is a specificity spillover. So it is HCG is capable in a higher number to stimulate TSH receptor. So more further discussion of the mechanism that I have put it in the slide shows that it is agonist, and higher that HCG and more higher evidence of hyperthyroxidemia, and that has been also shown by the study that I have cited before from England. And the other reason is the molecular variation. It has been proposed, or it has been that the sialic acid content of TSIs or HCG, human chorionic gonadotropin, is less as compared to TSIs. And it is believed that in beta sen of HCG, 47 to 48 peptide bond has been nicked, and that may be the reason for reduced sialic acid content. And low sialic acid appears to increase the thyrotropic potency. There is also possible this also increase the half-life of HCG and therefore more stimulation for thyroid hormone production. So in conclusion, teenage pregnancy, Asian and Native Americans ancestry appears to have high risk of molar pregnancy. 7 to 10% of identified molar pregnancy is associated with clinical and biochemical evidence of hyperthyroidism, extremely elevated beta HCG, and its molecular variation, which result is low sialic acid content, may be a etiological factor for hypothyroidism, and the longer half-life of HCG is also promotes the hyperthyroidism because of the prolonged stimulation of TSH receptor. However, a point to be made is that diabetes is not a risk factor. So, in conclusion, therefore, a diabetes patient is not likely to have high DT4 mole, and I want to make that point clear. And the vulnerable group I have already discussed in the slide. And so anytime any of the three things that has been discussed, abnormal size of the uterus, intractable bleeding, hyperemesis gravidarum, and the uteri size more than the date of pregnancy that prompted the diagnosis, and hyperthyroidism is something occurs about 7 to 10% of the cases. And I thought this will be an interesting case for not only the pediatric resident, it could be pediatric endocrine fellows as well as the OB/GYN resident. In my personal experience, I had another case that I saw when I was in United States Air Force. And so this is uncommon, but one need to think about it, and this could be fixed pretty easily. And OB/GYN consultation with endocrinologist for hyperthyroidism, and hardly they need any treatment for hyperthyroidism However, if the symptoms is significant, then a beta blocker may be a good idea. But once the uterus is evacuated, the signs, symptoms, and the level of thyroxine come down rather quickly. Thank you very much for following the discussion with me. I know this is a little bit longer, but slide is also bigger, and I did that one, as I said, deliberately, because so that you don't have to run to the textbook to get all the information. Video details will be present in the session, and the global pediatrics referral pages will be also submitted there. This case was also presented in a regional pediatric endocrine society meeting in Clearwater, Florida. Thank you very much.